Good evening. My name is David Blumenthal. I'm a faculty member at Harvard Medical School and director of the Interfaculty Program on Health Systems Improvement here at Harvard University. And it's my pleasure to moderate this evening's forum on racial and ethnic disparities in healthcare. This is a topic whose currency has grown dramatically in recent years. It's been very much in the news in the last few days for those of you who have followed the newspaper discussions of a recent federal report on racial disparities issued by the Department of Health and Human Services and at first issued in a much less controversial form and then in a rare display of correction and humility, an apology from the Secretary of Health and Human Services who admitted that the report had been sanitized before it was released. This issue goes back as far, I think, as the Tuskegee experiment. That's the sort of heritage with which this topic lives. And it has become much more active in the last 5 to 7 years. We're privileged to have a really terrific panel to discuss issues related to racial and ethnic disparities this evening. On my far left is Sally Sattel, a physician, a psychiatrist, I believe, and a resident scholar at the American Enterprise Institute and author and commentator. Next to her, Joan Reed, who is Dean for Diversity and Community Affairs at Harvard Medical School, the first African-American woman to be a dean at Harvard Medical School. And on my immediate left, Joe Betancourt, who is also a faculty member at Harvard Medical School and a member of the Institute for Health Policy at Partners Health System and has written extensively on this topic and also was a member of a recent Institute of Medicine committee that released one of the authoritative reports on racial and ethnic disparities. So I'd like to begin by first posing the general question of whether racial and ethnic disparities actually exist and what they are, what they consist of. And I think I'd like to start by posing that question to Joe.
Great, thank you. I think it's important as we begin this discussion to make a distinction between racial and ethnic disparities in health and racial and ethnic disparities in healthcare, which I think we'll probably focus on a little bit more today. It's been well known, at least nationally, there's been light shed on the fact that minorities have poor health outcomes, die at greater rates from cardiovascular disease, diabetes, HIV/AIDS, higher levels of infant mortality, lower life expectancy. And that's been well known for a fair amount of time. And in the late 80s, the Heckler report, the Department of Health and Human Services, I think, put a spotlight on this issue. It's important to understand that disparities in health do exist. And in fact, there are several factors that contribute to those disparities in health. We know that these populations that suffer from these disparities, that suffer from these conditions, clearly also suffer from what we call social determinants in health, which are they tend to be disproportionately represented among the poor, tend to live in housing that may exacerbate their health conditions, tend to perhaps have lower levels of education, and all these factors are very much related to health. So those factors are a major contributor. I think the second largest contributor to these disparities in health is access to care. And we understand that right now there's 44 million uninsured Americans, and minorities are disproportionately represented among those who are uninsured. So as I think about disparities in health, I would say yes, they definitely exist. Yes, those are two of the largest contributing factors. But I think what we found over the last 10 to 15 to 20 years is a robust set of studies emerging that show, in fact, that when you control for these factors, when you look at individuals who have the same socioeconomic status, who have access to care, and enter the healthcare system, we see disparities or differences in the quality of care that patients receive based most specifically on their race and ethnicity, not based on these other factors, access to care or social determinants. So it's a two-part answer, and I say, one, yes, there are disparities in health, and two, yes, there are disparities in health care I'd be happy to elaborate more on how we came to that conclusion about disparities in healthcare. It wasn't myself. It was actually among a committee of 15 multidisciplinary leaders of American medicine within the Institute of Medicine, which has been further independently verified by the American College of Cardiology, American College of Physicians, American Medical Association. We see health plans, hospitals, and even Senator Frist in a bipartisan bill laying out an effort to close the healthcare gap, and his findings track very nicely to the findings of the Institute of Medicine report.
Any other comments from our panelists on that, on those remarks? Nothing. If we agree then, maybe I shouldn't interpret quiet as agreement, but if we agree that that these differences in healthcare and health status exist, the question then obviously comes up: is this something we should do something about? And if it is something we should do something about, what kinds of things ought we to consider? And Dr. Satel, maybe you could address that question.
Oh, I certainly agree disparities exist. I think that was a very nice summary. The point of, I guess, tension between us sometimes has been how to interpret studies that show differences in healthcare. And boy, this seems very loud. And what I mean is that is one of the conclusions of your report, and specifically the one that says that some portion of the gap, of the health gap, may be attributable to bias, prejudice, and discrimination. That part, I'm just not sure of. I'd say the jury is essentially still out on that. I'd say that disparities are very real, and they're a very big problem. I don't believe that you've demonstrated that is a significant part of the explanation. But I would also just say as a teaser, I'm not even so sure that's important, based on at least the solutions I'd like to see to the problem.
Mm-hmm. And what are some of those? We can come back to the causes later. You can't hear us?
Oh, gosh, me?
Can you hear me?
I can hear myself.
Yes.
Damn.
You can't hear Sally, Dr. Satel? I wonder if it was after you moved the
Sorry.
microphone. Okay. What do you think?
Is that better?
What do our panelists think some of the legitimate solutions are? Maybe Dr. Satel, you could start in on that.
Sure. Is this better now? Okay. Well, I'm actually a big proponent. Before I tell you my big answer, I would like to say what I think the major determinants of the health gap are. I think they are access to health. That's huge. Access to quality health, health literacy, and attitudes towards health and health care. And I think, I've been giving this a fair amount of thought, that a major way to address these problems is by expanding the public health clinic system. I'm a big fan of community clinics. I don't feel as strongly as I know Joe does and other folks on the IOM committee, and I've been around the block with them a few times about the aspect of bias. But to the extent that there is mistrust, I don't know how much of it there is, but let's just stipulate there may be mistrust among some inner city minority populations for the mainstream medical community. It seems to me that the public health clinic is the perfect way around that, because it becomes an organic part of the community. It's staffed largely by people who work in the community, and so many of those what you call, I suppose, the non-physician staff are really often the bridge between the patients and the docs. So to me, it's not even that important that we worry all that much about diversity of the medical workforce. I'd like to see more diversity almost in the layer of health professionals between the patient and the doctor, because they're often the bridge. And you can have night hours, you can have the same source of care, that continuity. It just seems to me that every problem you mentioned, which are, you know, in the IOM book, is just, you could tick them all off with a public clinic solution. And in fact, since I've been invited to be the, I know I'm invited to be the Ann Coulter of medicine here, but I will put in a plug for Bush on that one. You know, he's put a lot of money into the public health clinics. Probably there could even be more, but that's really my solution. I didn't think we'd get to the bottom line so quickly, but if it were up to me, that's what I would do.
Joan, any thoughts on this?
A few thoughts. I think the first point I want to make relates to this issue of bias and discrimination. And I think the difficulty I have with this is in understanding how most Americans would agree that in our society there is bias and discrimination. And I find it difficult to understand how taking an MCAT or going to medical school will undo the bias and discrimination that people have, the experience, the stereotypes that they have as they grow up in a larger society. It just doesn't make sense that because you have an MD or a DO or an RN or a DDS behind your name, all of a sudden you have undone all of those things that you have learned throughout your life. So there is a part for me that finds it difficult to believe that physicians are so very, very different from the rest of the population. So I do think there's bias and discrimination. Do I think it's deliberate? Maybe, but not necessarily. I think it is a part of our culture and it needs to be addressed. That bias and discrimination may be related to mistrust, and we often go back to the Tuskegee affair, but there are many other areas that are not just about Tuskegee. But I don't think it's just an issue of mistrust. I think as clinicians, we bring to our interactions with patients, in our provider-patient interactions, our own experiences, our own values, our own views on the world, our own stereotypes, and those need to be addressed in those situations. In terms of the public health clinics, I have a unique experience in that I worked in community health centers for 8 years. And I think they serve a unique purpose in our community. I agree that oftentimes the community health centers have staffing that better reflects the community. At the same time, I don't think an appropriate response to issues of disparity and differences across populations is for those populations that suffer the most are relegated to only certain types of clinics. So the solution is you go to these clinics and this will solve your problem. I also think that the issue of, is it important to have diversity among the healthcare providers, or is it just adequate to find people in the community and then they can be the liaisons between the providers, leaves me feeling very uncomfortable because it ends up being a different kind of system. We're saying that people from these communities, to relate to their providers, to have their providers understand them, to have the proper kind of communication, they need to go find a neighbor who can communicate. But if you're from another community, you should be able to talk with your provider and have a relationship. That ends up creating a two-tiered system that I think is inappropriate.
So what are your solutions?
I beg your pardon?
Then I don't know if you were you
Go
just
ahead.
about to ask?
No, you have a response?
No. Oh, no, I have a
Okay.
question. So maybe I should
Okay.
leave the questions to you.
Well, are there other causes? We've talked about access to care related to socioeconomic factors. We've talked about discrimination. Are there other factors that need to be addressed if we're going to deal effectively with this acknowledged issue?
Yeah, what I'd like to do is take a step back. I think we've made an assumption here. We've talked about social determinants and access, and we've jumped into public health approaches. But I think it's important also, we've made an assumption that the audience even knows what the Institute of Medicine is. And maybe if I could just talk a little bit about that and that process, the findings and recommendations. We have a point, I think, to discuss whether those recommendations we see are valid or not. The Institute of Medicine is a nonprofit private institute of the National Academy of Sciences. When the government has questions related to healthcare, education, or policy, goes to the Institute of Medicine and says, I have this question, can you please bring a study committee together and look at the evidence and come up in anywhere between 6 months and 2 years with some findings and some recommendations. Some of the studies, a recent study, should all Americans get the smallpox vaccine, is the type of things that are debated at the Institute of Medicine. And the emergence of this literature around disparities in health, and then the literature around disparities in healthcare, was really, that piece of it was really seen as unconscionable. It was very difficult for policymakers to understand how people could have the same level of insurance and the same level of education and or socioeconomic status and receive a different quality of care. So what they did was ask the Institute of Medicine in 1999 to gather a committee together to basically look at whether there are disparities in healthcare with the full understanding that access and social determinants play a role. The Institute of Medicine then pulls together a jury of 15 individuals from around the country, leaders of American healthcare. A small percentage who maybe have some understanding of the issue, and a larger percentage of individuals who just are leaders in the American healthcare system and can provide perspective to the issue. I had the great fortune of being on that panel, and let me just give you a sense of who was on that panel, just so you understand that the Institute of Medicine was it's not an activist activity, and the report is not one that is built with ideology, but is one that is built with objective evidence. Among our panel that studied this issue over 2 years was the previous president of the American Medical Association, a dean of a nursing school, several practicing clinicians, a historian, a sociologist, an anthropologist, several people involved in medical education. Over the course of 2 years, we met every 3 months down in Washington to look at streams of evidence that included, first, the peer-reviewed literature. Why the peer-reviewed literature? Because that is the literature, that is what we in medicine, and when we look at evidence, hold up to the highest standard. That is, if a person puts out a study, it must be reviewed by their peers to show that it carries value and its findings are scientifically valid. In our studies, looking at, doing our literature search, looking at just over the last 10 years, we found 600 papers that focused on racial and ethnic disparities. Now, our task was a little bit more complicated in that we had to try to control for these usual suspects of education and socioeconomic status and access. Clearly, it is never a perfect practice. It's never easy to do all those things. So we whittled down the amount of papers to about 105 papers that really were fantastic. 40 of those papers, almost half, were prospective, meaning that they're not just looking retrospectively, a type of paper that is criticized, they're prospective studies. And of those 105, we looked at 15 in cardiovascular disease that were really held up as the top standard. Okay. So that's the literature search. In addition, we were able to look at, have the public and professional experts come and testify. We had the opportunity for focus groups. We had the opportunity as well for commissioned papers. So this occurs over 2 years, and we had several findings that I'll summarize, and then I think we could jump off from there. We said clearly that disparities in healthcare are unacceptable. They contribute to the larger disparities in health that we're discussing here today. We said that these disparities occur in a context where there still is persistent evidence of discrimination in the United States. We see racial profiling in criminal justice, lending, housing, and education. Did we find any 5 papers that showed racial profiling in medicine? No. And I would just say to Dr. Sattel that in the report, if you read it clearly, not once do we say it's racism, period, cut and dry, or it's discrimination. I think we were very careful to say that it is a set of multiple factors, that there are provider contributions, there are patient contributions, there are health systems contributions, and part of what we're trying to communicate is that everybody is responsible for a piece of this. Can we rule out discrimination in a country where the healthcare system was segregated only 50 years ago? Where we understand still that if we look at mistrust, the issue of mistrust, a recent survey by the Kaiser Family Foundation found that 65% of African Americans are concerned about being treated unfairly in the future in the healthcare system based on their race and ethnicity. And providers actually flip that in the sense that providers rarely or never feel like patients are treated unfairly. And so,
Joe, what would you do about discrimination?
Well, I think part of what we need to do, number one, is raise awareness of this fact. This is an issue, as I mentioned, the study on the doctor side, where it is anathema to us as physicians when you train as a healthcare provider to feel like you treat people different. We are trained to feel like we make decisions in a colorblind way. And I think that our approaches around education to, at first, just raise the issue and let people understand how we make clinical decisions, how we're susceptible to stereotyping. I think that that's an excellent first step. And I think sharing that clinical decision-making process with people who make decisions all every day but don't know how they make them is a very, very important first step. And I think we need to do better to control and observe for where these factors are existing.
Is the number of underrepresented minorities in the health professions a solution to this general type of problem? Joan?
I don't think the numbers of minority health professionals by themselves is going to solve the total problem. To make an assumption like that would make an assumption that those minorities are going to deal with just the minority patients and deal with these issues of disparity. So I don't think that's realistic. I think that it's also not realistic because the numbers are not there. They're not adequate right now for that. I think also that the health, as part of health professionalism, it is a responsibility of anyone that is trained as a health professional to address the needs of our society, of all members of our society, not select groups within our society. And so that the issues of minority populations, of rural populations, we're not only talking about disparities with minority and ethnic groups, we're talking about multiple areas of disparity, is something that the health profession should be concerned about. And everyone coming out of our schools should have some degree of concern. And so to that extent, I think you need to start to look at what does having diversity in our medical school classes produce. And I think if you look at some of the studies, much of which has been done at the college level, what you find that diversity within a class changes the climate. It changes the type of discussion. It changes the kind of understanding. It changes self-awareness. It changes concern for certain types of issues. The study that was done by Whitla involving Harvard Medical School students and University of San Francisco medical school students supports this in terms of medical students and what diversity in the class does. So a part of this is diversity in the class, and what does that do to the educational environment? A part of this is how do we train our students to be sensitive to issues that cross cultures? A part of this is the kind of things that Joe is talking about in terms of helping people to understand what is it that I bring to this situation? How do I think? How do I make my decisions? And how does that contribute? So just having that one black face in the class does not do all of that. So it's not a singular answer. But I think if we go back to a system that we had not too long ago, and one of the things I think we forget oftentimes in our country that it is in, if you look across this room, it's in most of our lifetimes that when we looked at our medical schools, there was one or two minorities within a medical school class. If we go back to that system, how are we going to have those kinds of cross-cultural experiences for our students? How are we going to have diversity of opinion and thought? How are we going to have diversity of opinion in terms of asking questions, research questions, policy across the board? So I think you have to have the numbers there. I don't think there's a solution to this that says that only one group should be represented within our schools. The numbers need to be increased, but that by itself will not solve the disparities problem.
One of the questions that comes up is how we would track, if we were to engage in efforts to reduce the ethnic and racial disparities by whatever strategy, how we would track our progress. And you quickly come to raise the question of where do we get the data to track racial and ethnic disparities? And I guess, Dr. Sattel, I'd be interested in your views on data collection with respect to race and ethnicity and how we go about doing that.
You know, I would almost defer to Joe. That is not my strong suit.
Mm-hmm.
But let me tell you what is, because
Okay.
I had a lot of answers to the questions that you asked the other folks. I agree. I'd certainly make the IOM report a journal club issue. Maybe,
Mm-hmm.
you know, repeat it every 3 months, whatever. Yes, it is very good for consciousness raising. I personally prefer the term that Greg Block uses, uncertainties. I think uncertainties in medicine is a better and less inflammatory term than bias and discrimination. The uncertainties that come from differences between class, differences between language, and I don't mean unacculturated populations that don't speak English where you need a translator, but subtleties that correlate with education and income and other kinds of shared experiences. And I do think they probably play a role. And I never said that racism, I never thought for a minute that you were saying that that was the entirety of the disparity at all. What you'd asked earlier, though, what would you do? And I'm very practical about these things. You said, what other kinds of determinants might there be? And I would say that in addition to the big ticket items of access, our health literacy, and I think so important are outreach efforts. And some of the most successful ones that I've looked into are, for example, in Washington, D.C., I believe in 15 other cities, there's the MOTEP program, Minority Organ Tissue Transplantation Education Program, which targets mainly African Americans because there's unfortunately such a high incidence of end-stage renal disease there, and educates folks about what transplantation really is about, what it involves, how to sign a donor card, that kind of thing. Not how to sign a donor card, the importance of signing a donor card. But a lot of education has to be done. You know, there was an article in the Times recently, I think it was about an article in the Annals of Internal Medicine that had to do with just what people's impressions were about lung cancer and then what one should do if one was diagnosed with lung cancer. And they analyzed the data by racial group, ethnic group, and what was it, I think 38% of African Americans in this survey believed that if they underwent surgery for a tumor and in the process of that surgery, the tumor was exposed to air, that it would spread. Some whites believed it too, some Hispanics believed it too, it just was more prevalent among the African Americans. The point is, a lot of people need to be educated, but that's the kind of thing that goes on at grassroots with black churches and Hispanic social groups and things like that. They also had an article in the Times, remember, about mammography in beauty parlors, you know, and mammography screening, you know. I think that's the level at which you want to get down to it. We know that asthma is a big problem in the inner cities. You want to attack that because the kids miss school and the moms have to stay home and maybe lose their job because of it. Just real practical, focused stuff. And I worry about, you know, bringing bias to things. I don't even know what that means. Yes, there are stereotypes because we generalize from experience, and some stereotypes are about whites and some are about blacks, and that's why we need the consciousness rate to make sure that you have been fair and give every patient the maximal opportunity to benefit. But I just think that I'd rather get out there on the street and do these things than worry about who's in my medical school class, because my patients now, I mean, 80% of them are African American, and I think there may be like 5 black kids in my medical school class, and it's in effect it's the patients you learn from a lot more than your teachers. Some from your students. You get broken up during residency with 5 kids. Sometimes you're in a rotation with 1 kid, 1 other student. You learn a lot from your patients and your supervisors. I mean, I just don't see that as such a big influence on my education.
We are in a school of government, so I feel like I should ask the question of whether there's a role for government in this general, in resolving these issues. I know there is legislation, has been legislation introduced by Senator Frist. Some of it is oriented toward training and increasing the number of people of color who are trained in the health professions. But I was wondering what, if the grassroots is where we want to focus, is government a part of the solution to making the grassroots effective in solving this problem?
You're asking me.
Anyone.
You're talking to me. Okay. I think there's a role. There could be, since so much of medical school education is publicly funded. I would think the government has a say in how that education progresses. And I think I know you're very involved. I just read your bio, but you're very involved with the sort of pipeline. You know, getting kids early so that they are competitive when they apply to medical school. That's great. What I worry about, and this is the controversial part here, is that affirmative action is a fantastic thing. I'm sure I wouldn't have gotten into my Ivy League college, if not, because when I went, women weren't quite that common. So that's outreach. But my definition of affirmative action is finding qualified people who are out there. My definition of racial preferences is lowering standards. And unfortunately, that sometimes happens in the name of getting a diverse workforce. And I think that only hurts, gosh, I think it hurts a lot of folks. But probably who it may hurt the most, and there's no evidence, I don't have any evidence for this, but is that if you're going to lower standards, and I'm not talking about an A versus an A minus, there's, in fact, I have an article here by Jordan Cohen, the president of the AAMC, an Association for American Medical Colleges, is very much devoted to increasing the number of minority, Hispanic, and black students. And it talks about the differences on average in qualifications and how they fare in medical school. And it's somewhat worrisome, I think, not because people are minorities, obviously, but because they are accepted with grade point averages and MCAT scores that are demonstrably lower, almost standard deviations sometimes. In fact, one nice study looked at kids, minority kids who were accepted competitively with their white and Asian colleagues, and they graduated the same rate and with the same passage on the rates of their boards. So though I don't have to say this is not about color, but it is not about color, it's about qualifications, which is why the pipeline is good. You get kids qualified along the way, and so.
Any response to that, Joan, Joe?
One of the things that oftentimes concerns me when we talk about affirmative action or talk about racial preferences or any of these types of things is an assumption of lowering standards. And I have to say that I want excellent physicians. I want excellence across the board. I don't believe in having different categories or preparation of physicians treating different types of patients. I do think that there are differences, and there are multiple reasons that we could go into for why oftentimes people of color, particularly underrepresented minorities, may perform lower on standardized testing or have lower GPAs. It is not clear to me, nor is it clear in the literature, how that correlates to how someone practices medicine later. And I think the major issue I have with this is that as a profession, we don't know how any of this correlates with how you practice medicine later. So we make these huge leaps and huge assumptions. So the challenge that I think is there is for the profession to step back and say, what is our duty to society? Who are we supposed to train to do what for all parts of society? And understanding that when someone comes into our medical schools, someone may be a researcher, someone may go into clinical practice, someone may do clinical epi, someone may be a policy person, someone may go into administration, someone may go into public health ultimately. But we're training people to do lots of things. They need to be clinically sound when they come out. And what are the attributes that are needed? What are the qualifications that correlate with what people do later and how they practice later? And I think what we have done is take an easy approach. What we've said is there are some convenience sample or convenience data that we can collect, such as GPA and an MCAT score. And because we have these convenience data, let's use this as our criteria for what's going to be a good provider later on, as opposed to stepping back and really starting to study what are the criteria that are important and how do they correlate to the physicians that come out later. I think we have been lazy as a profession because they are hard questions to ask, and we have not taken the time to ask those questions.
They are important questions. I agree with you, and there isn't much work. In fact, I've looked a lot at the research on performance in medical school, post in residency, and afterwards. There's almost nothing after, as you say, a little in residency, and a fair amount during medical school. So I wasn't just limiting myself to the undergraduate year, to the pre-med years. And this this article that I was referring to documents this very clearly, but anyway, there's just a fact that minority medical students, probably not at Harvard because you get the best of the best, but do take longer to finish medical school and do have multiple failure rates on the board. That's just average. Now, you might say, well, we don't know how that correlates with how one practices. Well, that's true, but I don't think I'd want someone to be my doc if they failed their boards 3 times.
Well, I think it's now our audience's turn. You've heard from us, and we'd like to open the microphones. If you go to the microphones, we'd like to know who you are and where you come from. Please, if possible, direct a question to a particular speaker. And I think there are microphones around the audience, if I'm not mistaken. There's some here and there. If you, please, sir.
I'm first. Oh,
They're all going to be from
it's
here.
louder than I thought. I'll give a little background first. I'm a former OMB type of person, so I ask the questions of either following the dollar or what the outcomes are. That's where we start and come down. It's interesting, just a little side thing on the popularity of the West Wing. Having been in that circle of how decisions are made, it's interesting because one of the things that does come out of that program, not because it's a good TV program and so forth, but I advise a lot of students and I mentor students in the health area of look at how decisions are made on things like that. Now, when I was at the Bureau, I was 5 among 300 people of color there. I was 5 colored among 300 other professionals. And at that time, this was in the 70s, it had an impact. And I'm trying to get the question I'm going to pose is government's role in this. Now that's way at the top. So the decisions are made up there on sometimes very light things, like things, because if you say something to the president or to someone who's in that charge of that might sway him one way or the other and say, let's go for disparities this year, put some money out for it. It'll come about just like that because the thing is already in Congress and it's being uprising. So government does have a role because a lot of the questions you raised are things that need to be studied for which there's no money. And that trickle up of those problems haven't gotten there. So I would just want to bring out the point. I have a lot of past things. I did a study once on the economic cost of kidney disease and discovered a whole lot of blacks were dying in the South from uremia. And it came like that because at the Bureau I had charge of health statistics. But the question is, how do the questions that you ask, and it's not a study in health or anything, is how you move something up to the level. And I don't know how to ask you if you don't know, but I want to bring it up as a point to discuss. Is there another method of bringing questions that you have into a form that then move up the line to have major decisions made on them?
Thank you. It seems to me like one question might be, how do we get funds and resources allocated to the questions that we've been raising here? And perhaps Joe or Joan
Sure.
would like to respond to that.
I think it's important to see what's happening as a meter for where we get the dollars. And I'll just share a couple of kind of contemporary examples that we're seeing around this issue and the leverage points around this issue of disparities in healthcare. So we see now that several large employers or purchasing groups, people who bring large employers together to think about getting their insurance for their employees, are now seeing and looking at the financial impact of these disparities on their bottom line and on their investments for health insurance for their employees. They understand that these disparities, if you're a large company and a fair amount of your employees are minority and you see this data about disparities, you understand that that's going to affect your bottom line as it relates to disability and death and You understand how you're not getting your dollar's worth when you invested insurance for those individuals. That leverage has been used now from the private sector. We're not talking about government. From the private sector, and we've heard very eloquently from large health insurers how they are trying to market their abilities to make sure they're addressing disparities. And so we see the market itself from that standpoint saying this has a cost, disparities have a cost to us. We want more out of our insurance companies who are going to be taking care of our employees. And so they are now pushing this agenda and using their leverage there for dollars. That's one piece. I think the government plays a role clearly, as Dr. Satel mentioned, from the standpoint of taxpayer money and investment in medical education, but also a mix of incentives, regulations, demonstration projects. I think many of the things that were proposed in the Closing the Healthcare Gap Act make a lot of sense. And there is a way that private industry and government, I think, could come together. This is costing America money. This is costing America lives and productivity. And so I think that's the way this issue is being viewed, and dollars will follow.
Over here, please.
I'm Alex Green, an internist at Beth Israel Deaconess Medical Center, and I'm going to address my question to Sally Satel. The question has to do with your comments about community-based health centers, which I think are very important aspects in providing care to a number of patients, not just minorities. And I've worked at community-based health centers before, but to suggest that community-based health centers are a panacea for disparities, to me, doesn't really jive, because basically, my concern is that if I'm working in a community-based health center and I know that patients of mine who are minorities are, when I refer them to a hospital, an academic medical center, to a cardiologist, to a pulmonologist, a surgeon, who potentially could be in any way biased and not provide them with cardiac catheterization, lung cancer surgery, renal transplantation at the same level with the same frequency that might be the case if they were white patients, that raises a concern of mine that community-based health centers alone are not going to be able to deal with those aspects of the disparities issue.
Yeah, the thing is, I don't share your assumption that the reason why you see sometimes, you see some of those differences in treatment. I just don't share the assumption that that's out of bias. And it might be. I just don't feel it's been demonstrated. And I actually wrote a fairly lengthy paper on essentially what would be the standard of evidence that we would need if we wanted to say this was about bias. And even that's tough, because then when you get into the issue of unconscious bias, you don't even know what you're measuring anymore. It becomes a default kind of an explanation, and it's not really falsifiable. Everything then becomes unconscious bias. Every difference we see can be unconscious. But let me be a little more specific about the kinds of studies I would like to see more of. The IOM book, which was a lot of work. I mean, it was a ton of work, clearly. But it was based mostly on retrospective studies, and that's not your fault. That's what there is. There's retrospective studies. And as you know, retrospective studies, they miss things because you're relying essentially on databases much of the time, Medicare databases, chart reviews, and there are subtleties left out that can be very informative in understanding why a certain clinical decision was made. Another problem, a huge problem with retrospective studies, is you can't ask the doctor why he made the decision. I'd love to see studies like that. Also, some studies, not all of them, I mean, different studies miss different things, but a lot of the studies also don't have information on patient preference, and that's important. I'm not saying that's everything by any means, but that's also an important variable. And you have enough variables that are missing, and remember, a lot of the times we're not talking, I think people get the impression sometimes that when you talk about disparities that, you know, most white people get this and almost no blacks get this. That's not true. One of the biggest gaps I saw was about 20%. I'm not excusing that by any means, but that 20% starts to whittle away when you start understanding more and more of those variables. So I'll try to make this fast, but that would be point one, more prospective studies. Also, another way to look at it is more audit studies, and those are very hard to do. They're big in economics, you know, where you send in a minority person and a white person to get a loan, and they're exactly the same on every parameter, but you know, the white person gets a loan and the black person doesn't. Well, that certainly tells you something. The one audit study that I'm aware of in medicine got a ton of attention, the Shulman Study. You're probably familiar with that. And to make a very long story short, even though it was advertised as finding a difference in referral rate for cardiac catheterization between whites and blacks, that kind of melted once the odds ratio was changed to relative risk. There really wasn't much difference at all. But that kind of a study gets at, you know, holding every variable but the race variable the same. And finally, third, another kind of study I like to see is ones where behavior of black doctors and white doctors are compared with respect to the way they treat their white patients and black patients. Again, I've only seen one study, I mean, there may be more, but I've only seen one study on that out of Yale, looking at black and white docs and their referral for cardiac catheterization, and found that both the white and black doctors referred white patients more than black patients, which is interesting. Some people have suggested that might be more defensive medicine on the part of dealing with white patients who are perhaps more likely to sue. In fact, that was one of the things the Shulman study showed when it asked the doctors, what do you think of this patient? Does he, in terms of likeliness to sue, the white patients got much higher ratings than the African American patients. But anyway, that's a window into whether we're talking about bias. And lastly, you also want to look at outcome, because we've been putting so much emphasis, understandably, on how much care is given. But when you look at the cardiac catheterization mortality, not morbidity, now that's a different issue, but the studies that looked at mortality, believe it or not, this may be because of the defensive medicine being practiced, the outcomes were not different. In other words, the mortality rates were the same, even though the African American patients got catheterized less. So we get sometimes, I think, too carried away with how much is being given as opposed to how is the patient doing.
Joe, you'd
It's a
want to add a
long-winded
comment?
answer to
Sure.
your question.
As a member of the Institute of Medicine committee who reviewed these, I'd be happy to sit down with you and go through all the studies and let me just factually clarify a couple of things, because I think there's facts and there's also perspectives in looking from the outside. A couple quick things. Majority of disparities we saw were in tertiary care, not primary care. Community health centers don't address the disparities we looked at. Second, when we think about the studies, as I mentioned, we looked at 105 studies that were highly qualified. 40 of those are prospective. We looked at 15 studies in cardiac care alone, of which 7 were prospective. We saw studies where talk about bringing patients in with the same condition, testers, right? How about African Americans, Hispanics, and whites going to the emergency room with long bone fractures, fractures where you could lay the x-rays on top of each other, humerus or femur, and you could lay these x-rays on top of each other, not Medicare, not retrospective, and we looked to see which patients got pain medication, and African Americans and Hispanics got significantly less pain medication. That is data that's very real. We looked at another study around renal transplantation that showed that African Americans with end-stage renal disease on hemodialysis tend to be put on the renal transplantation list less. The researchers circled back and asked the patients, did you not want to be on the list? And there was a little difference, but in fact that difference didn't explain the much bigger difference in them being on the list. So patient preferences, I think we could tick off as well. I think also the study that is referred to here about looking at black and white doctors. Now, if we're going to think about critiquing studies, I spent a lot of time looking at that study. And in fact, when you compared the black and white doctors, there were a lot more black doctors who were internists who had to refer the patient for a cardiac catheterization to white cardiologists. So here they were comparing black and whites, but the person who had their hand on the lever more often than not in that study was a white physician. Just facts.
And that means, then,
We have a questioner up there in the audience.
Good evening. I'm Harriet Washington. I am an ethics fellow at Harvard Medical School. My question is for Dr. Sattel as well. I have read quite a few of your readings.
they're all going to be for me, I think.
I wouldn't be surprised.
Yeah. Go ahead.
I've read your work quite extensively, and I must say that your writing style is considerably more powerful and less qualified than some of the statements you shared with us today. But I wanted to ask you about one in particular, because tonight you said that and I quote, "I'm not sure whether some important health disparities it's important whether health disparities are ascribed to racial bias." And I found that a perplexing claim, because if you don't explore the etiology of these biases, how on earth can you hope to approach them? It's just, that perplexes me. And the understanding of the etiology, if it is ascribable to provider bias, how would you know this if one elects to ignore it? I'm thinking of your very intriguing essay, I think that was entitled, "I Am a Racially Profiling Doctor," in which you spoke at great length about these biases, these disparities, and some of your views about behaviors of minority group members and how a lot of them are attributable to the bias. So if you could expound on that for us, that would be really illuminating and help round out your comments tonight. Thanks.
Oh, yeah. So start with the last one, and don't go. I might ask you to remind me of those questions. But the last one just talked about was pretty much about pharmacogenetics. Mm-hmm. It wasn't had nothing to do with bias or anything.
Excuse me?
The last paper you were talking about that was.
I am a racially profiling doctor.
Right. That was about pharmacogenetics and just the fact that that we're discovering that drugs can be metabolized differently by different ethnic groups, and some drugs may or may not be more effective. What that was
I read
about.
it.
Okay.
And I think it ranged a little more widely than that, if I remember correctly.
Well, that was what I believe the point of that was talking about. It said diseases aren't colorblind, so doctors shouldn't be in that way. And so it was, yes, if you had a patient, what some people have said was, you can't just look at a person and say, oh, you're black, that means, for example, you have sickle cell anemia if you have bone pain. Well, of course you can't. I agree, that would be a very crude way to approach it. But that there are, but just pointing out the fact that there are statistical likelihoods that people who are, when they talk about race, I don't even like talking about that word because it's so complicated.
That book must have been very painful for you to write then.
No, it has to do with the fact that when we're talking about the differences, but to the extent that there are biological differences, it really has to do with an ancestry, gene pools, and that's where you trace them back to. So in other words, if someone comes into your office, if you want to be really clear about it, you would say, what is your ancestry, if you were puzzled and thought they might have had some kind of condition that was more prevalent in a certain group than others. But anyway, that's what that was about. When I said that I think it's hard to get to the bias issue is because it is hard to get to it. But it's that it's so overwhelmed in importance by other things that we know about in terms of access and health literacy and quality of care that it almost makes more sense to put our efforts into the big ticket items that we do know about. That's really what I meant by that. I can't remember.
But if I could just interject, you did write extensively, though, about patient behaviors.
Sure.
Right, and when you read about patient behaviors, I think you, in fact, you did talk about the behaviors of your patients who were predominantly black, and the kinds of behavior, a lot of it was very predictive. In other words, you were saying you expected certain behaviors. I'm asking you about that because some of your comments tonight about racial disparities in health care do seem to have focused upon behaviors of patients, some that have been, I think that no one argues with. But that seems to be, a focus of yours. I mean, there's no question that African Americans tend to avoid medical research more than they should, more than is good for them. But is that, in your opinion, a chief factor or the only factor worth investigating?
I think it's certainly one factor. People's attitude towards health and how they see care. I certainly think that's one factor.
Can we take a question up here, please?
This is a question for Dr. Betancourt. I'm Judy Hirschfield-Bartek. I'm the nurse coordinator at the Beth Israel Deaconess Breast Care Center. I've worked with women with breast cancer for many, many years, and I've seen the disparities in healthcare. I'm just wondering, could you define for us, because I respect the IOM report and everything it had to say, what is quality care? Because I think that's something that's very difficult for us to get our arms around. It's beyond patient satisfaction. I, like you, you're a nice doctor. because I've seen wonderful healthcare providers give really lousy care, and I've seen people have access to a lot of care, and a lot of care does not define good care. So I'm just wondering if you can sort of help shed some light on that.
Sure. I should put David on. David has written the preeminent papers on quality and could probably answer this way better than I do. I'll just give my brief answer as I see it. I definitely see quality of care as a vehicle of addressing disparities. I think quality of care to me is much more than patient satisfaction. It is, you have a set of evidence-based guidelines, right, ways that we think are going to give us the best healthcare outcome. And it's assuring that quality to me is assuring that we adhere to that evidence-based guidelines, to those evidence-based guidelines. And that, for example, that diabetics get hemoglobin A1Cs checked, get their seen by an eye doctor. Quality is a way to bring out the evidence of science to the practice of medicine. And so that's the way I would define quality in the shadow of a person who defined it much better than I ever can.
And won't add to that tonight. Ellen.
Thank you. My name is Ellen.
Sorry, can I just ask one additional question? Sorry, Ellen. So in terms of breast cancer, obviously I have a bias towards my concern in working with breast cancer, women with breast cancer. The only definition of quality care is mammography. But yet we have this definitely public health problem in terms of breast cancer. And
we could have a long forum on the definition of quality, but that's another night.
Okay, fair enough.
I think we'll move down to Ellen Kagan.
Hi,
Thanks.
my name's Ellen Kagan. I'm the host and producer of a consumer advocacy healthcare show here in Massachusetts on public access all around the state. And one of the things that's bothering me is that do you think the healthcare system, which really is in such horrible shape right now, is exacerbating the situation? Because what we're seeing not only is the discrimination for blacks, for Hispanics, for everybody, but I've seen it as a caregiver for the elderly, for so many groups of people, and now we have concierge medicine coming up, which is going to add discrimination again. So do you think we have this horrible problem because of the healthcare system itself? Is it just exacerbating? And can we really, can our students be trained? Because, you know, they're in such a rush in the hospitals and so forth. I mean, there's such stress that I witnessed among the doctors, the nurses, and whatever, that you wonder sometimes whether it's just discrimination or are they just such horrible shape themselves emotionally.
Is there anyone in particular
You know, I've
that
seen
you would
it.
like to respond to that?
Yeah.
Joan, would you care to take that up?
I think there are systemic problems. I think you'd be hard-pressed to say that there are not systemic problems. I think one place to begin is by acknowledging that there are problems. I find absolutely amazing as we talk today about is there discrimination or is there not discrimination and what goes on in medicine and to what extent does the profession and the healthcare system respond to these types of issues. If you look back just a few years ago, it wasn't the healthcare professional, it wasn't the healthcare system that said it was wrong to have segregation of patients within institutions or across institutions so that if I was in the wrong city at the wrong point in time, I could not receive care, or that physicians couldn't practice in certain institutions. It wasn't our health professions that sat back and said, this is wrong. This is wrong how we're treating patients. It was a Civil Rights Act that came out and said, you have to change what you're doing. So I think there is a part of denial within the healthcare system that we have problems that we need to start to address.
Over here.
Hi, my name is Sarah Bleish. I'm a second-year student in the health policy program here, and my question is for Dr. Reed. There seems to be a fundamental tension on the panel about whether or not there are disparities in health and whether or not there's a racial bias in terms of patient care. And so my question is, at the medical school level, what do you do to address it within students? Is it like specific classes that students have to take, or is it integrated in the entire curriculum? And then on the professional level, is there some consensus that doctors get training later in life to try to make them more socially aware as they deal with different communities?
I think you've hit on some of the major issues that are being discussed right now in terms of medical education and cultural competence training, and when do you train and how do you train, and is one class during your first week of medical school and an orientation adequate to help prepare you to be a culturally competent physician later. This is largely the work that Joe Betancourt has been doing, so I'm going to ask him to also follow up on this. I think there are two parts. There are parts of who and how are we training now? How are we training the physicians and the residents that are coming through our system now? But we have hundreds of thousands of practicing physicians that are already out there, and they need to also be addressed. So I think there are issues in terms of continuing education. I think these issues of awareness here have to be brought forward. The question is, how do you get that done? What are the appropriate mechanisms to teach adults, to teach people, to change practice? Can they be brought to bear in these issues? Should it be required? You know, if you look in Massachusetts, there are requirements in terms of physicians for certain types of to maintain your license. Should there be requirements that relate to these types of issues? I'm not sure, but I think those are the kinds of things that people are starting to look at now as we look at revising our medical curricula. To what extent do these need to be incorporated? For me personally, I think that to isolate issues around culture, race, difference, all of the different kinds of things we're talking about, to have them as a separate class that's taught separately over here minimizes their importance in terms of students. I think they need to be integrated across the board. I think they need to be revisited across the board. But that also means that we have to address it in looking across our curriculum. But, I mean, that's
I would just add, yeah, I think that's right. But I want to say, you know, there's tension, but I think there has been some agreement. I mean, I would say that clearly public health, there's acknowledgement here that disparities exist, and I think public health is plays an exceedingly important role, broadly defined, to eliminate disparities in health. There's no two ways about that. And I think we shouldn't put all our eggs in this basket of just bias. That's not what we're saying either. Clearly, the healthcare system has the way it's currently constructed has an incredible impact, and its evolution over the last 15 years has in many ways, I think, exacerbated this. So this isn't just about, you know, this conversation and our recommendations weren't just about addressing bias. And so I think that's where there's agreement. There are public health issues here, there's health system issues here, and I think that there are issues around education. Now, we know around these issues of education, what we're trying to do around cultural competence or cross-cultural education really is an expansion of an ongoing movement that's called patient-centeredness, which says how can we use those 15 minutes that are allotted to us in a healthcare visit to use those very effectively, to have the tools and skills to get at some of these beliefs that Dr. Satel mentioned that exist, and they cross cultures. And there are tools and skills that allow our providers and give them the best chance to provide the highest quality of care to any patient they see, regardless of race, ethnicity, culture, class. You don't flip a switch and change people's perspectives. And so I think, you know, that we need to put that in context as well. But I think education, both from the standpoint of awareness of disparities and tools and skills to understand how we make decisions, to understand how to communicate more effectively, are an important strategy.
In the balcony.
Hi, my name is Yvette Matola. I'm one of the fourth-year emergency medicine residents at Mass General and the Brigham. I have a general question, which I think Joe actually just started to address, which is to Dr. Satel specifically, but in general, taking a step back in problem solving. When you're trying to identify the root of a problem and trying to come up with solutions, you do that at multiple levels. I don't disagree with you that it's important to go into the community and do outreach. I think it's very important, but I don't think that's all that needs to happen. I think all these other things that have been raised here tonight are real, and I've experienced them as going through the medical system, both as a Latina and as a woman. And I went to a medical school that was very open, and we had a class on how to be a sensitive person, basically, which is called Introduction to Health and Human Interactions. And I thought, well, how ridiculous that we have to sit here and learn how to talk to people and how to be sensitive to people and learn about the biopsychosocial model of medicine. It seemed like it should be something that was obvious. And what I've realized by going through 4 years of medical school is that it's not at all obvious, that there's things that we don't even think about, and there's definitely things that if you don't come from a background where you would even think about these things, that would come up. A lot of people studied pharmacology during those classes, which was really too bad in the end. But I think it at least heightened your perception and ideas of these things happen. I do think that it's important to have diversity in these classrooms. I went to a predominantly white medical school with 60% men in my class, and when a professor of biochemistry said, the reason that we have a cervical cancer epidemic is because of the promiscuous low socioeconomic class women in our country, I was the only person that raised my hand and said, "Excuse me, can you repeat what you just said?" Because I was really astounded. And I do think it's important to have diversity at all levels of education, both in the classroom, both as teachers, in residencies. And I do think that the problem is at multiple levels. I think you have to identify it at multiple levels, and I think you have to address it at multiple levels. And I wanted to sort of just get your opinion on that.
You know, I think one of the best ways, sadly, to get insight into what patients are going through is to end up being a patient yourself. And I'm not going to certainly hope you don't get, people shouldn't get sick, but boy, that gives you a ton of insight. Yeah, I have nothing, I don't have any problem with classes in which one talks about, those issues at all. And I have nothing, I should say, I have nothing against diversity. My question is always, it would be absurd. My question is always, though, sometimes at what price are we reaching for it? And that's where when I mentioned, I worry when we have to lower standards. That's why I like the pipeline issue much better. You mentioned another point, which the lady, I think two ladies before you mentioned too, is that, how are you going to know how to fix some of the problems unless you look for the solution? And the example you gave, Joe, about the pain, those studies, I have to admit, they are puzzling. I don't understand them. But that's exactly the kind of study that you would want to use as a heuristic to do the kind of prospective work to find out why are these differences in pain prescribing? I don't know, but I am not, you can have bias as a hypothesis. I guess I'm just not willing to say that it's been determined that that is. So sure, but that's a way to get to the answer. I suppose I just want to go further before I'd be satisfied in a way that that's the answer. And the reason why I feel we can afford to wait is because we know so much of the problem already that we can start working on those other, what I've been calling big ticket items about expanding access and that kind of thing.
We can take one more question, and it's up here in the balcony.
Good evening. My name is Gary Flowers. I'm a visiting fellow at the Institute of Politics this spring, and I'm also vice president of programs for Rainbow Push Coalition in Reverend Jackson's organization. I'm directing this question to Dr. Sattel. Given the plethora of discriminatory data in nearly every facet of American society, your characterization as it relates to the health field as uncertainties, I believe is what you said, as opposed to discrimination, maybe as naive as saying that since African Americans had full employment and enslavement, that it was good for them. The question I have is, given your statement and doubt about affirmative action that might produce doctors who didn't do well on a standardized exam and relates to their competence as physicians, are you equally as doubtful with respect to the titular CEO of a nation having academic difficulties? And does that relate to his competence?
I'm going to address the question in terms of not affirmative action. Remember, there's a difference between affirmative action and racial preferences. And in terms of lowering standards, yeah, I will always think that is unacceptable for physicians. That's what we're here to talk about. There are two quick things I want to say, though, is that much of, I believe, the push for racial preferences, which the AAMC endorses, are based on, I think, two misconceptions and one kind of complicated reality. One misconception, and I'm just basing this on data, maybe there are other data to be collected that I'll change my mind, but maybe. That overwhelmingly minority patients prefer minority docs. I don't think the data show that. I think patients pretty much want a good doc. We want to get good doctors into bad neighborhoods, and that's what we want to do. So I don't think patients are that concerned about the color of their doctor. And if they do care, I'd like to see more options for patient preference. That would be, that would be great. But I don't think they care that much. I think they just want a good doctor who'll spend time with them and who cares. And there's the other assumption is that same race doctor-patient dyads have better outcomes. And I don't think there's compelling evidence one way or the other that that's really true. The third point that people say is that minority medical students are more likely to practice in underserved areas, or minority docs are more likely to practice in underserved areas. And that's true. And that's great. If they're feel a commitment to the population, that's wonderful. I think sometimes they do practice there because they might not be as competitive, but I also think it's because, come on guys, be realistic. But in any case, I think to get good docs in bad neighborhoods, no matter what their color, we just need incentives for that. I don't think we need to lower standards to do that.
Last word from either of our panelists.
I'll just do again, which is the clarification of fact. A couple of things. I think standards are an interesting word, right? Because we think about standards, and we think about who makes standards, and we think about racial preferences, and we think about preferences given to people in positions of power with the use of a phone call when many people don't have access to those quote-unquote preferences. So it's not just about racial preferences. And I think when we looked at the Supreme Court decision, there was many briefs, amicus briefs, that came in support of diversity for a variety of different reasons, and also an understanding that to attack these preferences is to basically disentangle an entire system that's built on preferences for a variety of other different reasons, yet racial preferences are attacked much more than others. I would say that among the studies we looked at, I agree. Listen, two patients being of the same background, I think that there's concrete benefit when a patient is mistrustful and the doc looks like them. Of course, there's an issue. And if there's a language issue there. But we did see studies, 4, that showed that minority patients preferred minority doctors. We did see evidence to show that minority doctors, no evidence to show that they were less qualified, practiced in underserved and minority communities. Is our goal diversity to ghettoize physicians? Absolutely not. Is our goal to lower standards? Absolutely not. Do we want to maybe perhaps look at our standards and look at what our needs are for an increasingly diverse patient population? And not lower. I don't want a doctor who's failed their boards, but I think we need to consider what can we do to make sure that our healthcare workforce looks like its patient population in a way that displays excellence. And I think that's what we're about.
I agree with that 100%.
Well, it's always great to end on a note of agreement.
I
I'm
agree
confident
with
that this topic will not go away and that we'll hear more about it.
But I will. Today.
And I want to thank our audience for their attentiveness. I want to thank our panelists for their contributions.
Thank you.